Well, I would say as a practice we have a well-established process of significant event monitoring, where as a no-blame exercise we look at incidents that occur in the practice and then share the learning and implement changes to improve patient safety. But I would say that we became aware a little while ago that incidents that are occurring in our practice may well occur in other practices, and there is something about the wider sharing of incidents, because there may be themes which appear which should be identified, more than just simply within the practice. So we have been reporting into the SIRMS process for certainly the last 6 months. We previously used to report into the NECS process, and I think we found that a little bit on the clunky side. I think SIRMS is an easier process to report into. The wider sharing came home to us more recently, about 6 weeks ago, when we had an incident at practice where a bacteriology result came from the lab. Now, it was a very long report. It had a lot of additional information and advice attached to the result, and as a result it was truncated on the practice system. Now, when it's truncated, ideally, having read the initial report, you would open up the rest of the report and review the rest of the text. But not unnaturally, the clinician responsible at the time assumed the rest of the text simply referred to some of the advice that he'd already read, and then he actioned the treatment for the patient based on the result. Subsequently, it appeared that there was a further laboratory result appended to the end of the report where a further infection was shown, and this was not treated for a number of weeks as a result of it not being picked up. Now, this was reported on SIRMS, and shortly later the laboratory contacted us as a practice to say that this had been an issue reported in both South Tyneside and Gateshead, so it was clearly a significant issue, not purely isolated to this practice. And as a result, we're now doing some work with the laboratory to think about putting some kind of sort of banner headline on the top of results indicating that there is more issues for the clinician to attend to and to avoid this sort of issue happening in the future. So I think that's really quite a good example of sharing information and incidents that occur at your practice with the wider system.
SIRMS reporting is easier than any system that we've had previously. Very easy to use, it takes about 5 minutes at the most, and we get feedback via the newsletter on a monthly basis, and it does actually give us feedback on the themes that might have been reported by other practices, and we can see that the improvements to services that patients have benefited from us reporting on the SIRMS system.
During CQC inspections, they're very keen for practices to be seen to be reporting their incidents externally as well as internally, again for the rationale of looking at themes. And they'll often ask whether nurses or doctors report into the National Reporting and Learning System. Now, SIRMS connects directly into that system, so by reporting into SIRMS, you're ticking 2 boxes actually, which is going to be very effective, again, to demonstrate as a practice that you are learning from events.